Welcome to Care Beyond Barriers. I'm Christina Farr, and today, along with my panel, Dr. Tom Kelly, Dr. Hannah Allen, and Dr. Simon Koss, we are unpacking the topic of regulations, systems, and incentives. Right, let's get into it. All right, so regulation. May seem boring, unsexy, but so important for everything that's going on right now with healthcare and AI. Can each of you share what you think is a great example of regulation done right within the context where you operate today, whether it be the UK, whether it be Australia, or anywhere else in the world? Let's start with you.
All right, well, very random, but I was a surgeon by background, so I always think of like physical devices. So, like X-ray machines, you want a device needs to behave the same way every time. So when I look at an X-ray as a doctor, I know what an X-ray is and what it should look like. In software, I think of things that make decisions. So like retinal scanners that come up with autonomous diagnoses are interesting. They were some of the first like medical device approved AI for diagnosis tools. I think digital diagnostics in the US was one of the ones that met the founders and was always inspired by in the early 2020s. So yeah, physical devices is what I think of when I think of regulation. Yeah.
Nice. I think we're at this sort of pivotal time where we're not quite sure how to regulate a lot of the technology coming out. The UK and the EU are sort of renowned for having quite stringent and tight regulatory processes and approaches. I think one of the things that we've done quite well recently is thinking about how to plan ahead and to regulate for what products will be out and what the roadmap looks like for in 6 months, 12 months, 18 months' time. And one of the sort of ways that we've done that is put together the National Commission. So the MHRA has put together the National Commission, and part of that is to really kind of take on board industry voices and opinions. I'm part of that kind of technologies group of the National Commission, and I think it then allows them to have these really sort of agile, different, innovative perspectives, not to just have the sort of historic approach of, perhaps people would think you'd be sitting in a bit of an ivory tower making decisions that are going to really influence and perhaps stifle innovation. I think it's a new way of approaching and staying ahead of the game.
For me, it was point of care testing devices. So very early in my career, graduated medical school, and the standard treatment for acute myocardial infarction was serial monitoring of cardiac enzymes. And between when I graduated and when I actually started practicing in the emergency department, point of care troponin T testing had come in, and all of a sudden we had a new way to manage this condition that was really common in the emergency department. For me to be able to trust that device had gone through a regulatory process meant that I could just shift my attention into, all right, how do I manage through using this device? And it took that concern away and created a level of confidence for me as a practitioner.
Yeah, I think that's the kind of key thing, right? It's about basically, as doctors, like we have enough to deal with, let alone trying to assess every single device or tool or software that we use in our practice. So I guess it's regulation sort of about trust, that for things that could influence our decisions or affect our patients, that there's some body that's doing the hard work of making sure it's something I should be using or not. And then I just, I basically delegate responsibility to those bodies, and then I just do my job with my patients.
But how do you instill that implicit trust? Patients have implicit trust in us as doctors because we've been to medical school, we've got, certificate of completion of training, we've done X, Y, and Z exams. How do you instill the same kind of implicit trust in, novel technology, AI, etc.?
I think it starts with understanding risk.
Yeah.
So it's not good enough for me to understand all of the positive benefits of a technology. I want to understand the risks. And once I do that, then I can move on and actually use it with confidence.
So I'm going to push back on all of you because we mentioned risk, we mentioned patient safety. All these things are absolutely critical. But let's talk about time horizons. We'll take the example you mentioned, digital therapeutics, digital diagnostics.
Yeah.
Great example. In the States, we had some amazing entrepreneurs come around about 15 years ago, 20 years ago, and say, we think there might be a digital approach to treating this condition, whether it be ADHD in children, or maybe whether it be obesity management, and it can be done digitally. So good idea. Then, of course, you need all the evidence to be collected. Then you need the regulatory bodies to say this is safe and effective. And then, this is the critical step, you need a reimbursement pathway. How does this all get paid for? So from A to B, 20 years. Meanwhile, if I'm an entrepreneur, if I'm an investor, 20 years is far too long to start to see the very beginnings of revenue for something like that. So how do we square all of this, that I think is really the right intentions with the realities of what it takes to develop a successful business today? Tom?
Yeah, I think it's really tricky. Luckily, I don't invest in medical devices, so I don't have to make these decisions. But I think it biases to like a limited subset of conditions that could be affected by these tools. Basically, it has to be something that, if true, would like fundamentally change healthcare in some amazing way. I don't know, my silly idea is always like incubation pods. Like if you could just, get in a pod and sleep for 20 years and wake up, that would be an incredible technology that would change the world. So then you could get an investor to invest in that. But could you get an investor to invest in a new ultrasound that's maybe 10% better than an existing one? Probably not, because of this life cycle. So at least for us, I guess we're in an advantaged position where there are like surrogate pieces of value before you need to get device regulation. So you can kind of like, make money as a company, get users, get validation before needing to prove that this thing operates in a fully autonomous way. But yeah, for the people that build in medical devices, it's really tricky. I don't have a golden bullet for them. I guess you want to try to do as much pre-market validation as you can, so that you're confident that it's worth it.
And being in an environment, I think like a pro-agile environment where we're all starting to move towards, and I actually think the US is probably better at it, where you can collaborate in a kind of sandbox testing environment where, you can really stress test these types of tools. And we're starting to see some work in the UK where you can kind of bring your tool, your product, and you can stress test it with a population of patients in a simulated environment. And I think where we kind of bring together industry, academics, and real world environment as much as possible to stress test these things in an agile way. Otherwise, to your point, the regulation will constantly be playing catch up, and will never catch up with actual industry.
So that's probably more a reflection on the model of regulation, because if it is taking 20 years and technology is there that can make a difference today, what might a different model be? And I know that in Germany, they've got the Digi fast track process where you can actually have an exception and then you can get your device out there in use. But then there's a period of scrutiny where you're collecting your medical claims and you can develop your evidence. We can't wait for regulation to be available for some of these technologies that are really impactful.
Yeah.
That's one part of it that I philosophically aren't misaligned for me. Like I feel like as a patient, I can understand the risk profile, and maybe it's because I've been through medical school and I'm an edge case. But like if I can look at the evidence, understand like objectively what has been proven, what isn't proven. I don't know, like the amount of people I know taking peptides now that haven't even had human trials, and they like anecdotally feel like that it makes a difference for them. But they've read all the papers that they can and they feel like they've come to an informed decision. So I do kind of like models where you involve patients and empower them more and giving like understanding this is the state of this device. Like you can decide for yourself whether or not you feel like it's appropriate. But that's not really how medicine is typically done. It's sort of like there's a standard and patients aren't exposed to anything that doesn't meet that standard. Whereas those lines are kind of starting to blur, where like consumer companies and apps are starting to sell things that don't necessarily have evidence as like wellness treatments. So they're kind of like skirting the borders of what is medical practice and what isn't. So I suspect hopefully it'll be a bit more like patients get involved in the choice. But obviously the big academic centers, it'll never be like that. Yeah.
So you bring up an amazing point around wellness, because wellness, as we know, it's a bit of a wild west, far less regulation around anything that technically qualifies as wellness. And we see this playing out now on a global stage where it's become the lines are extremely blurry around what is medical and what is wellness. And we saw this happen over the past number of years with companies, say, for instance, like Whoop, which is, I'm actually wearing the Oura ring, but Whoop is another wearable where they came out with a way to monitor blood pressure trends and said this is really wellness for wellness purposes. And in America, the FDA said, no, blood pressure is inherently medical because it's tied to so many different chronic conditions. So really, this is not wellness. And of course, a big debate has broken out subsequently around this issue of can you do this and claim it to be wellness if you're not diagnosing disease? So how do you all see that going with this constant debate? And how, if you're a regulator, aren't you in an absolutely impossible decision?
Yeah, I think this is my anti-capitalist, conflicts with my entrepreneur in me. But I think that those cases, they just are devices, because someone is going to read that blood pressure and then go look up online, and it's like a butterfly effect. Like, you can say that they're, inside the Whoop ecosystem or inside Oura, these investigations are just used to influence non-medical decision-making about their life. But, someone's still going to go use that measurement to go decide whether they see a doctor or not. So you have to be held to that standard, I think. And it's always about commercial gain in most of these cases. There's some service or subscription they can sell to, get live blood pressure monitoring or whatever it is. It should be, to me, about, is it going to impact how medical practice is done? And then if it is, then that's fine. Just, grow up, do the work. If you're not willing to do the work, you shouldn't play in that category. Stay in heart rate monitoring, SATs, other areas.
When we talk about, capacity issues and problems with the healthcare sector, we always talk about the hospital system and how we need to change things within the hospital system. I see a role for these types of devices, regulated or not, in reducing the influx into ED or into primary care, at that point of access. And without this sort of, wellness space, self-care space, it's going to be incredibly difficult to reduce that kind of demand for healthcare as well.
I think the consumerism of medical devices or consumer devices that do wellness monitoring has actually been net good for society. The real question is, what's the risk of patient harm? And if it's a pedometer tracking your steps and you're moving more, that's actually not going to cause harm. And then does it start to become a surrogate for the clinical care you might otherwise receive? So when I think about that blood pressure, there's a conversation to be had if your blood pressure is trending high, let alone how accurate is the device and how does it get calibrated and the rest of it. So when there's patient harm involved, I think regulation has a role to step in and provide that assurance.
Yeah.
So people, at least in America, where I currently live, they like the idea of consumer cash pay sometimes because it feels pure in a way, that it is based on a transaction that a consumer agrees to because value is being provided. I like my Oura ring, so I continue to pay for it, right? Whereas the rest of the system, the incentives can feel very misaligned, very messed up, that you're paying, you don't even know in some cases what you'll pay until the bill arrives. In the case of a consumer environment, you know exactly how much it's going to cost. So people like that and they're gravitating to it. And as a result, we're seeing an explosion. How would you react to that there's this whole shadow healthcare system now developing?
I think it's a natural byproduct of the fact that we've got democratization of devices and information. And like I said, I think that's net good for society. I think anything that up-levels health literacy, but it does create this grey zone. The grey zone is as these devices start to approach clinical care, when does that cross the line? And I think we just need to evaluate based on patient harm.
Yeah, I practice in London now as a GP, but previously I practiced in Devon in the southwest, where, health equity is pretty poor, and accessibility to good healthcare. They have high levels of poverty, and lower socioeconomic groups. So my concern with consumerization of healthcare is how does it widen the health equity gap, right? Because your average person living in a small suburb not earning a huge salary, perhaps can't afford all of these brilliant products that are going to improve your overall health score and, understanding of your own health, in comparison to perhaps a lot of the patients I might see in London. Where does that kind of leave us as a society as well? Widening that gap is a concern of mine.
Yeah, I think for me, I think it's a good thing. Like in the US, the way the employer pays health insurer model makes the incentives really perverse. Everyone believes in free market capitalism. The idea that a patient can choose is like really sexy. And when you're not sick, you can. So I can choose between, Function Health or Superpower or whoever. But actually, most of healthcare, you can't really choose. You're sick and sometimes very sick, and you need to go see someone. And it's not like, as I'm feel like I'm about to die, I'm well, should I go to NYU or should I go to New York State? It's like, I'm just going wherever I'm being taken. So then I end up having to pay whatever that health system charges. And yeah, it's weird to me coming from an Australian context where the government sets the price for visits and medicines, and it's not perfect, but there's some sort of, because the government funds it, there's some kind of ceiling and floor on what things can cost. So I think basically they're emblematic of maybe how healthcare should be done. There should be some fixed price or some service and some setup of value for a given thing, like a GP visit is $30 or whatever. I don't think they're going to ever actually solve the problem because they're limited to like the wealthy basically. They can afford to pay for these amazing services, and I do think they're great, and I do think people should use them. But when you've broken your leg, an app can't help me. There's like always some line where it's like, okay, now I have to do the real thing and go to a hospital or go to a practice. But I think so Australia is a good blend. We have private and public. Private takes some pressure off the public health system. Yes, there's health inequity, but that's the world. Like there is inequity. Those that can pay, they should. And yes, they get slightly better care. But at least that takes some pressure off the orthopedic list in the public that has a long waiting list. So yeah, I think it's more like systemic issue of like how health insurance sets up a bad incentive in the US.
When I think about the developing world, the gold standard test might be a barrier to care. So you might need to go get genetic screening. But if there's an app on your phone and you can take a selfie and that can analyse for facial dysmorphism, and instead of giving you a diagnosis, it's a screening test, or anemia is another one. If you can take a selfie of your conjunctiva and then analyse that against a standardised colour palette and screen for anemia, now you actually don't need a blood draw and a lab at the back end to the rest of it. And that can actually start to increase health equity as well. So I think there's probably a role for modern technology to approximate to increase that health equity.
Mm. Yeah, and it's sort of like, what's the alternative? Like if in a given location you couldn't otherwise get access, then maybe like a slightly lower sensitivity and specificity of your tests is acceptable because, the alternative is no test.
Yeah.
Sure, there's a gold standard, but like if you can't get the gold standard, well, then you're willing to accept lowest bars of care to get something.
So I think we should talk about incentives because we have systems around the world like the US that really are structured as fee for service. So you pay for a service rendered, which is oftentimes a procedure, and it pushes the healthcare system into doing more because that's how payment works. I think the future that we're all excited about and really is having mixed success when it comes to the reality of how it's playing out is payment should happen when there is a good outcome that is achieved. And we're seeing the very early innings of that in the US. I think other systems have different kinds of incentives. The UK, for instance, much more around how do we deliver a standard of care to everybody as equitably as possible. I think that's a different kind of incentive structure. What do you think is the right incentive structure that we need for a new world where AI comes into the fore and you see human physicians and AI starting to work together, in some cases to do less, as you mentioned, with could the AI take on some of this work? So how should incentives and payment ultimately flow in this new world?
It depends what we're trying to measure, right? We first of all need to think about what are we actually trying to improve here. And for me, historically, we've always been looking at, we've always focused on quantity as opposed to quality. Right, like how can we get more patients through the door? How can we get doctors to see more patients? You know, how can I squeeze in 40 patients in my day in a clinic and I end up feeling exhausted, you know, and wonder why 42% of GPs in the UK want to quit and never go back, right? So I think we need to flip it on its head and think about how can we actually improve quality of healthcare and actual sort of kind of patient outcomes. What does that look like? I think that is where we need to head towards.
Do you think the capitated models work? Because you guys work in it, right? That's like the maximal version of it.
Yeah, I think some elements of it do, but you know, in the UK we use something called QOF, which is Quality Outcomes Framework in primary care, and a lot of those metrics are there's a financial incentive attached to it in primary care that if you hit certain QOF markers, you will then receive that reimbursement. However, it doesn't lead to necessarily the right sort of care because you're not necessarily going to be looking outside of what is immediately in front of you and thinking about preventative care and thinking about asking other questions. You're wanting to get your QOF box ticked to get that reimbursement. So again, it's quantity rather than quality of care. How can we think of a mechanism to support quality? It's the same in the hospital system. We have the RTTs, which is how can we get somebody out of A&E quickly? How can we get them through A&E, you know, within that 4 hours? So we're not breaching, but we're putting them onto a pathway. So you're incentivized to tick the box to say they're on a pathway. That's not improving patient care.
Because we had that as well. So at the hospital I used to work at, they started inventing new wards that weren't the ED, but were places you could put someone.
Yeah.
Because they would meet the criteria, but it was actually, and it was like a holding bay. Man, those terrible things happened in those bays because they had no doctors and it was a disaster. So yeah, the incentives are tricky sometimes.
Yeah.
I think Hannah, you mentioned the important word, which is prevention. So under a model where there's acute episodic sickness, fee for service can work. But when you're actually starting to manage lifestyle-induced risk and chronic disease, then unless you've got a value-based care framework, you're actually not going to make sure that you're addressing the social determinants and having that conversation. And then I look at different countries and how their spend to outcome ratio tracks, and the Nordics are doing particularly well and have been doing forever. And then I look at where the US is sitting, knocking on the door of 20% GDP, and you know something's got to change. So I think that shift away from fee-for-service, which can drive episodic care but not actually get down to treating the underlying condition, to a value-based framework, makes a lot of sense.
And in the Nordics, that's a really good point. And they invest heavily in kind of upstream, don't they?
Yep.
And the community-based care as opposed to kind of siloing care and putting it all into reactive healthcare. Yeah.
By the time you're sick with an end-stage chronic disease, you're in hospital, you're expensive to the system.
Yeah.
That's cost. But then it's patient outcomes as well. And from a clinician perspective, there's not much you can do either. So ounce of prevention is worth a pound of cure, so they say.
Yeah, I think is for taking into AI. So if you think like marginal cost of healthcare labor kind of goes to almost zero, like if, you know, Heidi can phone patients and text them and do some of the things we can do, then you have to have a model that has some incentive structure to reduce the chronic cost or risk to some sort of value-based something. Because in 5 years, like again, back to this idea of having like a herd of Heidis, for every doctor, there could be many, many extensions of them that are doing lots of different care coordination, having conversations with patients, helping them plan their diet or order shopping for them or who knows what. But all those things would be incentivized on that person's lifetime risk of downstream cost and conditions. So I suspect it'll be government level engagements where they look at like a population and they say, how much would this population typically have costed us? Where are the areas where we spend? Can we give 10% as a carve out to AI systems over some period of time and see what happens to that population? And I suspect that we will be able to prove that we can do quite a lot to reduce cost. And maybe that's how those funding models happen. because you can only make a doctor so productive. Like if I'm getting paid per visit, we run into this all the time when we're talking about notes or something that's about productivity. It's like, does the doctor really have to see more patients to justify this? Like we're capturing the conditions they have better, and we're maybe helping them with a plan, and that has like other downstream benefits. But when someone buys it, they're just like, does my doctor see more patients? Which just feels very microscopic relative to the system.
That's what the conversation always boils down to, that in the UK as well. And we've seen from the data across ED, same-day emergency care, we're saving, an external evaluation was done and we saved 85% of time in the same-day emergency care. But right now that just costs the hospital 85% more because of the way that they're funded. Yeah. So we have to rethink how the government approaches the contracts with the secondary care systems.
Even in New Zealand, for example, like we had small pilots demonstrating that their emergencies would be like orders of magnitude more productive if simple intervention, just like something writing the consultant's notes for them, the attending's notes done, and they would see 1 or 2 more patients a day each, which on a country scale would be really significant. And so they procured it for the whole country, which is, that would never happen in most countries. So it's tricky level to operate, but I do think that's how you have to almost view it as a game of civilization or something. Like, where do I deploy resources? Like, what's the best? Whereas if you're trying to fix the incentive in like one doctor, one patient, it's just like you're in the like atomic unit of the body, and it's very hard to create the right incentive, I think.
Why do we think, like you guys were closer to the New Zealand work, why do we think that they were so kind of open and agile in the way that they approach things and kind of think about things?
Yeah.
So a couple of reasons. They've had a strategy of digital health for a long time with relatively little progress against that. And then that creates a perfect opportunity for shadow AI to crop up. Yeah. So they knew the groundswell was there and the demand and the adoption. So I guess that was the first thing. Second thing, they just were challenged with the demand and the constraints. Third thing, and this is really important, they don't have an electronic health record nationally in New Zealand. So they weren't paralysed by thinking about how do we integrate this. They just got on and deployed it, and it was taken up so quickly.
Yeah, you can print Heidi's notes.
Put it in the paper chart.
Yeah, I agree. Yeah, sometimes the system gets in the way of itself sometimes, like thinking through all of the different like IT governance, cybersecurity, and then by the time you get through all those things, it's like they lost focus of why they're actually doing it in the first place, or like where does the actual decision making power? Who's the owner of this? Like who actually wins if this thing happens? And generally, that's the trickiest part of being in AI, because you're trying to find like who wins if this happens.
If you could design a perfect system where AI was part of the way that a patient got care, and you can be a physician in this scenario, would you want to be paid on the basis of an outcome was achieved and it was a combination approach of AI and human decision-making and human touch that got that patient to that outcome? Or would you want to be paid on the basis of doing the work and then the AI is just free and used as part of that? Like, what in this perfect system, how are you getting both incentivized and paid? Because it's obviously one and the same thing.
I think there's like a human problem and then there's like the outcome you want. So the human problem is, as a doctor, I spent however much training, like let's say $500,000, and I have loans. So I think we have to honor our physicians by giving them like some floor. Like they have to know that for this specialty in a given region, like you're going to be paid X. I think that is like an acceptable thing to make the economic incentive of becoming a doctor make sense. Like that, you have to have some floor. Then you want to have some variable performance-based element, which should be mostly about chronicity and your impact on actual cost to the system.
So a bonus, basically, like any of us would have a bonus.
Exactly. Yeah,
we did a good job.
Yeah, and maybe it can be just like some sort of like actuarial, like you're getting a percentage return on your harm or cost reduction for the population of patients that you see. And then I think AI can play a role in that, the bonus part. So if you're using Heidi really effectively and you're doing all these outbound calls and you've got it at the front desk, making it very easy for patients to get in to see you, and you're using evidence, and like all these things will just come out in the wash. Like they'll just be better doctors. You'll be better on that chronic element of managing your patients. And then maybe as AI gets more autonomous, AI can be funded for some of the more acute-based visits as well. In the Medicare-based model, it's like for a certain activity, if you're medical device approved, the AI can get funded like a doctor can. I still think most of those models will be supervised by practice or something. So maybe like, Heidi's working for Tom's medical practice, and Tom's medical practice gets $4 every time the AI prescribes, and they pay us some subscription or something, or usage or whatever. I think that like that model makes sense to me. Now I know that, there's so many stakeholders, like I don't know how to solve all the rest of it, but that's intuitively what makes sense.
Yeah, we can't try and boil the ocean. It's too much to do.
Yeah.
But I think we also, to kind of execute that scenario, we need to like not work in silos. And I think certainly in the UK, I'm sure in the other GAs as well, it's almost like us versus them, right? In primary care, we get rejected referrals because you didn't tick this box and you didn't answer that question. We have to work together. We have to work with secondary care and work on a population together to support each other, rather than it being like siloed working in primary care and siloed working in secondary care. I think that kind of continuity of care has to work well.
A really good point, because, we talk about AI as having no precedent, but the precedent is there, which is that care team, which is less expensive than the physician. And we have countries around the world that use that care team very well. I think the Nordic countries is a great one. And then countries around the world that don't. And the US is a good example of that, where that care team is not practicing to the top of their license, whether it be a nurse, whether it be a physician's assistant, whether it be a nutritionist, a physical therapist.
Yeah.
So why could the AI just be an extension of that care team?
Interesting.
So when I think about it, and this stat carries over time, I think it came from McKinsey, they said about 30% of the economic cost in healthcare is waste. And so rather than looking for how do we raise revenue and raise productivity, how do we start to strip out low value activity, all of the redundant forms and duplicative.
Imaging.
And that's not why people got into healthcare, to do low value, cognitive, repetitive tasks. How about we identify those and lean in with technology and then free up this critical workforce challenge we have? And I'd pay for that.
I remember some of the surgeons would order MRIs again because they couldn't get like the codec to match. So then like the image looked weird, so they just didn't trust it. So it's like, oh yeah, we'll just do another one, like another few $1,000s down the drain. Yeah, I think the care team is a really good way to think of it. We usually use the word care partner, like it's this like partnership between you and the system. You're in control, you're supervising it, but it can over time do more autonomous things for you and your patients. Yeah, the tricky part is what you were saying about like the QOF. So like what are the metrics that you measure? Like the HEDIS measures in Medicare and Medicaid. It's like you have to be careful about the incentives you create, because then there will always be bad actors that manipulate them for their own gain. But the hard part is I don't know if this tracks everywhere, but I still think the average doctor is not always financially motivated. Like they're motivated, hopefully, by their patients doing well and doing the right thing by them. There'll always be a group that are bad actors that make the news and whatever else. But there's I think like fundamentally there's like a goodness, the Hippocratic Oath. Like we could have been investment bankers, So systems that trust that, I think, back to you, like, oh, it shouldn't be that how many patients you saw. Like, you tried to do your best. Sure, there's this bonus element, but like just entrusting doctors that they are trying to care for their community, I think is a good thing and something that we should try to do.
I agree.
You need a yin and a yang in any good system where you have, there are forces that will drive costs up, and then there need to be equal forces that drive costs down. And in America, you have forces driving costs up and nothing else, really. There isn't a significant force driving it down. And AI is a tool, right? It's a technology created by humans for humans. So a lot of the early AI will only serve to drive costs up, whether it be more coding of routine visits, because the AI is in the background correctly pointing out that there are more things that can be billed for within this encounter, or any number of different things that we see on the ground. But I think, to your point, waste, that is a huge opportunity, but again, comes back to incentives and ensuring that systems have both that yin and that yang. So I'm curious if you will share that fear that I do, that the AI tools will be used for the driving up of costs rather than the bringing it down across a lot of systems.
Yeah, in US healthcare for sure. Like it's my biggest concern, because what you can do is you can there are all these businesses that exist that I still am shocked exist. So sorry if you're listening to this and you're one of them, but it's like a system that reads the medical record to find referrals that were made that didn't happen, and then we'll chase them to make sure that they have that visit. And that probably didn't happen because the patient got better. But now you're chasing them being like, oh, have you seen the respiratory doctor? Like, oh, you really should see them. Oh, my shortness of breath is better.
Go see that
you should.
Specialist.
Yeah, exactly. You should really go see them. And then the system makes more money and the business takes their cut of that, finder's fee of that visit. So with AI, that's, you can do that on max scale autonomously on every note, like just drive visit volume or drive whatever incentive is there for them to make more money. And like, it's just waste. I don't know, it's grass, it's not good for anyone.
No, but then if you can put in good preventative measures and access to good preventative tools before the patient even, when it's well care, right, when they're still well, before they've even had to reach out and make contact with the doctor, that's where we need to put the investment in to even reduce them getting into the system in the first place, And while you guys were talking, I was thinking about a case I had with a patient who was actually suicidal, and I was trying to refer them somewhere. And it took me about an hour to find anyone that would take this patient on. I was literally sitting there with all my other patients waiting in the waiting room. We talk about waste, but that's the kind of system that we're dealing with at the moment, where we can't even find anywhere to refer an acute mental health crisis to.
I have chills. It's awful.
Yeah.
What we're seeing globally. And it reminds me in a way of, I've been fascinated to monitor these mental health chatbots, which are really all AI. And I think part of me is, maybe a bit suspicious because I've used AI and it tells me I'm great all day long.
It's working.
But
yeah, exactly. Yeah, you're brilliant.
Definitely boosts the ego. But then on the other hand, shouldn't you be freed up to manage a patient that is suicidal instead of sitting there with somebody who's got mild anxiety that could reasonably be taken care of by an AI chatbot that's really tailor-made for this use case? And maybe we call it emotional resilience. We don't call it therapy, and then it's wellness, and it brings us into this non-regulated framework. But I really feel so conflicted about it because I can see both the good and the bad.
Yeah, I think at the moment we're operating in a generic system that's constrained by scarcity of access to healthcare. So, and it's a generic approach. So everyone has 10 minutes, regardless of what problems you bring to me. So whether you have mild anxiety and I'm going to give you sertraline, and you're going to want to come back and see me every single week, or you're having an absolute mental health crisis, you've got psychosis, you need acute access today, I've still only got 8 minutes with you. We need to be using AI and technology to allow us to have a fluid and dynamic approach as to how we engage with patients and patients engage with us, so that it's not when we don't have these kind of peaks of access and then nothing, to support both us as clinicians in how we support patients, but also for patients to access help in a timely way.
When I think about the cost structure of healthcare, you've got some big line items. So you've got workforce, you've got facilities, you've got medications. Where AI is obviously going to play a big role is in that workforce element. And there's only so many human workers to go around for overwhelming work. So this isn't about eliminating headcount like it would be in some other industries. This is about using the same workforce to deliver greater access, better outcomes. And the question really is, what are those use cases where we can actually strip out low value load, the busy work around work, and tier that off to technology safely so clinicians can do what's important, whether it's managing that acute patient or getting on and seeing the next patient, delivering higher value care, and then having all of the rest of it that gets in the way managed in the background.
I agree. Administrative use cases, so obvious. What about lower acuity and that work around which patients do not need to actually be seen? And then how do we make a judgment call around that?
Yeah, I think it will happen. So we're starting to do some of this front desk comms sort of work, and we We find that maybe 15% of patients really want to speak to a human. They don't want to speak to Heidi.
We're talking about scheduling, questions around
but even gathering some history. So we have some specialists who use it as a way to initially screen, like whether or not these are referrals that they might want to take. And, have you had this done? Have you had this done? Have you got your GP referral? Blah, 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 blah. So I think that's probably what will happen. It will become maybe marginally harder to get to see Hannah because Hannah's precious. No time is precious. And she only got so much time in the day. And probably it already sort of happens in the UK where you have this triage of like which patients do you actually book in. So it's crazy. They have a weekly rush where, all their appointments are booked. So then on a given day, sometimes the doctors will be doing this voice triage of who gets the appointment, who doesn't. That's a bit brutal, but I do think having some AI as initial screening advice, and especially as we start to incorporate evidence and giving patients like real self-management, or even starting to do some initial investigation so that maybe, the history and the investigation is done so that when you're coming to see the doctor, it's the pointy end and you're figuring out what to do. So 2 visits becomes 1 visit. These are all things that I think will definitely happen. It's also better as a patient. Like I spend half my day going to see the doctor. I could walk out with pathology requests. Then I get my blood drawn. Then I have to come back on another day. It's bad for society. I'm 2 days off work and I've taken up double the doctor's time. So I think those are really good use cases. Like it's intuitive. We'll still have to demonstrate we're safe. We'll have to prove that, this is a device that works and is consistent. But I think they're good use cases for everyone. The mental health is always tricky because mental health has this implied high risk of, and also just generally as a piece of software, your ability to accept the risk, like, the risk of suicide in someone who has mental health problems is always going to be there. And so no matter what you do, like there's a fist risk, even as a doctor.
Yeah.
Like it doesn't matter what you do, there's always going to be a chance that someone does something terrible to themselves. And so it's like one of the hardest areas, I think, for people to accept it. So really they just have to demonstrate, I think, that, in a population that had access to this, here are the metrics that we moved, like whatever risk scoring system. And then here's, the adverse incidents, and it doesn't change that much from the baseline. But there will definitely be papers written and TechCrunch will write articles about how, someone was managed by this app and they ended up committing suicide. And that's obviously horrible, but that was just a static risk that was there, it's very tricky.
We need to be really careful around sort of deciding for the patient whether they are sick enough or, do you know what I mean? Because I've had patients before where I thought, they're fine. And then they come in and see you. And we get taught in GP land to try and figure out what the hidden agenda is, right? Because on the surface, they might come in and say, I've hurt my finger. But actually, they've got X, Y, and Z going on at home and they're actually really depressed and, feeling suicidal or whatever. But unless you unpack it and you have that headspace to kind of sit there and really effectively communicate with the patient, you're not going to get to the bottom and the crux of the problem. And I would worry that if we were kind of siphoning people off as actually, you're too well, you can't come in, we will run into problems. So we need to figure out how to allow access, and maybe again, it's to self-help tools at home, right? But then at a certain level, it's flagged to go and see the doctor, but rather than being a complete kind of gatekeeper.
And maybe this just works itself out over time where these AI tools and other technologies just become so efficient, and the people that could just be satisfied with something that's much more kind of technology based and much cheaper and easier, those people will take themselves out of the running, leaving all of you with the patients that really need you. Because I think ultimately, as much as I love spending time with all of you, most patients don't want to be taking off half a day to see the physician. So we should make it far easier for the ones that need that help to get it, and for everybody else to just be moving on with their lives. So with that, I would like to thank all of you for joining me. It was such an important conversation on incentives, reimbursement challenges, and everything else. And what a pleasure. Thank you.
Thank you.
Next time, we'll come together to unpack the loss of trust and shared direction. Trust seems to be eroding on all levels, from patients towards clinicians in the healthcare system writ large, and from clinicians towards their own leadership. So how do we rebuild trust and create a shared direction?